This podcast is sponsored by Great Seminars and Books. Have you ever thought about how we can become leaders in geriatric care, or how we can break out of the silos of rehab to serve older adults to the best of our ability? Well, myself and Dr. Carole Lewis of Great Seminars and Books will be holding a free webinar titled Breaking Out of the Clinic: Strategies to Become Leaders in Geriatric Care. This webinar will take place on October 9th, 2017 at 7 p.m. Eastern Standard Time. To get access to this webinar, just go to seniorrehabproject.com/great. Hit me.
This is a Senior Rehab Podcast, the podcast for rehab clinicians that want to better serve older adults.
Hello, friends. Welcome to the Senior Rehab Podcast. Thank you for your time today. On the show is Alisa Curry from California. She is the coordinator of rehab clinical programs with Washington Hospital Healthcare System in Fremont, California. She has been an integral developer in the growth of a top-ranked joint arthroplasty program serving over 1,500 patients per year, known as the Institute for Joint Restoration and Research. From committing to a more efficient, patient-centered, and holistic approach to patient care to staff development, she has been completely dedicated to the program's continued success. Dr. Curry moderates an online discussion listserv of over 2,400 patients internationally to ask questions about total joint arthroplasties, and she has also developed the Total Joint Replacement Special Interest Group for therapists practicing with this patient population through the Academy of Acute Care Physical Therapy. She teaches, she treats patients, and she is an overall awesome person. Welcome to the Senior Rehab Podcast, Alisa.
Thank you. I am happy to be here. This is a pretty amazing thing you got going here.
It's because there's people like you that are involved. So Alisa is a member of the Senior Rehab Project Facebook group. So it's been cool to have you in there and to have you in on some of these conversations. But I Googled you and saw that you are an educator and you work with Great Seminars and Books among, many other companies, and you are the go-to source for total joint replacements as far as I can tell. So,
well, it's I tell you, there's a lot of people out there that are doing great work. I am hoping to, change the field in my own little way, but there's also some other really amazing people. I just happen to be more on the acute care side of things, because Total Joints has always been focused on the outpatient side. And there's obviously some great research in outpatient treatment, from, from Michael Body and Jennifer, Lapsley Stevens and, Lynn, Snyder-Mackler. I was reading her stuff when I was in PT school. So, I've always been kind of interested in this.
That's awesome.
And so, this kind of fell into my lap in a great way, and it's kind of driven my whole career.
That's cool. Well, let's get kind of the highlights of your career in terms of just what have you done along the way up to what you're doing now?
Well, let's see. I started at the hospital in 1996 as a part-time therapist, and in 1997, we had a surgeon come in, Dr. John Dearborn, who decided he wanted to just have a practice that was solely joint replacement, which was a novel concept, and he wanted to build a center. Our original title was the Center for Joint Replacement. And so he wanted to come in and have a center that was completely focused on that. So we had a clinical nurse specialist in orthopedics. We had a unit that we could, take hold of and actually just keep it to joint replacement and clean surgeries, which we would have hysterectomy patients on that same unit. And, they asked from the rehab standpoint who was interested, and I said, well, I'm interested. And so that has gone from me being interested to writing protocols for our program to seeing the growth over, the last, going on 19 years almost.
Wow. What have been the biggest changes in how we handle total joint replacements in general? Are there some general themes in how we've changed our views on the rehab side of things?
I think from the rehab side, we know that the thing that works the best for our patients is education first and foremost. And that's improved, I think, over the years. I think that as therapists, we are always there, working, I like to say working in the trenches with our patients, because we see them more than the surgeons do. And we give them a lot more information than the surgeons do. So I think that in terms of education, we being more educated can educate our patients better. And I'll tell you, the internet, it's a double-edged sword, because it can be the best thing and the worst thing in terms of patients doing their own research. But I think in the last, joint replacement has changed a lot in the last 10 years, because the implants have changed, the cements have changed, the surgical techniques in the last, 10 to 15 years have changed. And probably the most recent change is that pain management has really come around to be very effective. And that, again, can be great in that our patients are doing better faster. But the one thing I always tell patients is that the one thing that never changes is the rate at which people heal. And so we're constantly trying to run that battle between these medications intraoperatively that control pain so well that patients feel like they can do anything, and then they blow up and then they don't achieve the goals that they want to achieve.
Yeah, that's a good point. And I've noticed too, especially with the talk of the opioid crisis and, just the addictiveness of some of these painkillers. I've had a lot of patients that have had total joint replacements that are very leery to take their medication, and almost to the point where it's really impacted them in a negative manner in terms of the rehab side of things, which has been interesting.
Absolutely. The fact that the APTA is really taking a active role in highlighting physical therapy as an alternative for patients is huge, because in joint replacement, you can't do joint replacement without some sort of pain management.
Right.
And I tell people you can't build a house without a hammer. And so you can't do joint replacement without the right combination of medications. However, it really is a combination. They've, in joint replacement now we use, in surgery they use two medications. They use Exparel, which is a liposomal bupivacaine. If you imagine it like a pomegranate. And essentially, each of the seeds is carrying a little bit of bupivacaine, which is an anesthetic used by the anesthesiologist intraoperatively. But they've encapsulated it, and it releases over 24 to 72 hours, and giving patients a little better pain management right out of the gate. And then the second one is tranexamic acid, which helps to decrease bleeding, and bleeding actually can cause pressure in the joint. So the inflammation of the tissues, the pressure in the joint, the pain that patients feel, that combination has always slowed them down. And now we're controlling those factors better. And so patients are doing better faster.
Yeah, that's incredible. So, excuse me, I was thinking about how to frame this conversation. And, I was just going to kind of hit on each joint that we commonly see in rehab. But then I asked the Senior Rehab Project Facebook group if they had any questions, and we've got probably 10 questions right now.
Yeah.
So we got a lot of responses. So I'm thinking that just the group members are going to comprise or kind of direct our conversation. Is that okay with you?
Absolutely.
Okay, so we'll kind of start at the top and work our way down. So we'll start with total shoulders. So we had one question from Nicole Nexon, and she said, what is the maximum expected range of motion return? And should we be expecting limited range of motion? And then the last part is, what have you found to help manage patient expectations and or frustration? So I guess first off, what is the maximum expected range of motion return with someone that has a total shoulder replacement?
Well, if you're talking passive range of motion, you really want to shoot for 150 to 180 degrees of passive range of motion. When you have a total shoulder, it's really going to be dictated by, first of all, the type of total shoulder, because if it's a standard total shoulder versus a reverse total shoulder. Biomechanically, you're weakened in that process. So essentially, a lot of our geriatric patients, especially the ones who waited to have a total shoulder or who have put it off so long that the rotator cuff can't be repaired, that's our patients who are having the reverse total shoulders. And in an ideal situation, you're trying to get back, full passive range of motion. But as I said, the patient may not regain strength enough to be able to get through a complete range of movement. That doesn't mean that we settle. It means that we really try to maximize what they can do. In terms of external rotation, you'd want to get them, externally rotated to, I like to use function. And so I like to get someone to the point where they can touch the back of their head. Because that, for a lot of patients, that is a milestone, and so with it, one of the key things that I teach patients is that, the only point where their shoulder complex is touching their body skeleton is at that sternoclavicular joint, and everything else is soft tissue. So a lot of the work comes in, the scapular adjustments and trying to free that up, trying to identify trigger point. Trigger point release works great, with a lot of these patients, and just the hands-on. I have a lot of admiration for outpatient therapists and shoulders, because I don't see a ton of total shoulders in my practice, but when we do work with them, it takes some patience and it takes some, focus to be able to get the range back.
Yeah, I had a good bit where I was previously in Columbus, Ohio. Now I'm in Lexington, Kentucky, and I haven't had any total shoulder patients yet. But I'm wondering, from your perspective, is there a trend with this surgery? Is it being utilized more with the patients we commonly serve, or is it being utilized less?
I think it's actually utilized more. One of the stats that I talk about in my lecture is the fact that that there's I think the stat was that there were about 5. I'd have to pull it up. I'll see if I can get that for you, Dustin. But it essentially talks about the number of people that are living with rotator cuff problems. And a lot of people don't want to do something about it until it really interferes with the things that they want to do in life. If it's causing pain that keeps them up at night, or they find that that they're very inhibited, then they're ready to go see a doctor about it. But because of the range of the elbow, many people will function with a torn rotator cuff, the rest of their life.
Yeah. So Nicole also asked, what have you found to help manage patient expectations and or frustrations? And this could apply to any surgery, but how would you answer that question?
Having a realistic discussion at the outset is really a good way to start, because you have to identify what's important to the patient before you ever get into anything. Because a patient who's not committed and engaged in what you're doing, if they don't understand where you're trying to get to, then the buy-in is half the battle. Getting a patient to follow their exercise program, getting a patient to follow their precautions for, if they're over enthusiastic. So I usually try to identify what a patient is trying to get back to, what's important to them, identifying the goals, and then I break it down in terms of function. If I have a patient, for example, that likes to golf, and their dominant hand, they've had a total shoulder on their dominant hand, then we talk about the mechanics of golf, and we talk about, what type of movement they need, and we talk about what types of functional things they need. And then it makes sense, because then they have something to equate it back to.
That's a good point. And I think one thing that I've learned just through observation is just because someone has gone through just kind of the hospital's system of the total joint replacement, don't assume that they retained a lot of the information.
Correct.
And I'll do a start of care in home health, and see the hospital's beautiful surgical folder with all this educational information, and detailing the surgery and what to expect, and all this really good information. And the patient probably sat through a 1 hour surgical class ahead of time, just to have a solid understanding of what was to come. But when I see people in the home health setting, even though they've gone through that stuff, they still sometimes don't even have a clue of what happened to their knee or hip, or whatever joint, but or what to expect from the rehab side of things. So I think it's good to always assess that how effective that education was, especially if you all are after the acute care setting.
Yeah, absolutely. It's so true. Because, I think sometimes we can be a little quick to judge our colleagues in different settings. What did that acute care therapist do? They just got you in and out of bed. That was it. And what did the home health therapist do? They just came over and saw you and then they left. And, so we are quick to judge, but the reality is we need to have a better dialogue in between our different settings. Mm-hmm. As an acute care therapist, if I foresee a problem with a patient, I'll call forward and I'll try to talk to the company, and I'll give my number and I'll say, have the therapist call me. And, we don't do that enough in our profession. Mm. And if we're going to if we're going to carry this title of doctor, we need to step up and we need to be more accountable. Yeah. So, we call forward to the next setting, or if you don't understand what's going on, you call back and call back to the previous setting and, talk to the therapist and find out, what that patient did. Because many times patients in the hospital, they're sleep deprived and, pain medicine on board, and they don't retain education very well. Mm-hmm.
Yeah.
Yeah.
So let's move on to hips. So Nicole next, and she asked, what is the incidence of THA and post-op incontinence? And does the method of surgical approach affect the incidence?
There is some correlation. When that's one of the things that you can see. And I think you have to look at it from two perspectives. It's not so much that total hip causes incontinence, but you have to think about it in terms of the ability for patients to be functional, to get up and to go to the bathroom and to perform their self-care. Patients are hindered. Someone who has an anterior total hip or a posterior total hip can have the same limitations before surgery. They can have difficulty with external rotation of the hip. They can have difficulty with bending at hip flexion to be able to sit down on a toilet, or to be able to open their leg enough to perform their self-care. So that can actually lead to patients becoming more incontinent, losing the pelvic floor muscle. And there's also, I was looking at a couple articles that talked about incontinence. I mean, there's some studies out there that touch on incontinence, back to the early 90s, that talk about the correlation between hip arthritis and incontinence as a function of patients just not physically being able to get to the restroom fast enough. Mm. And therefore they lose that dysfunction. They also discussed the fact that there's another study that I was looking at that talked about anterior approach hips, and whether or not having an anterior hip replacement allows better control of one of the muscles that helps to add support to the pelvic floor. And I think, I'm sorry, go ahead.
No, I just said interesting.
Yeah. So I think from a physical therapist perspective, what I like to focus on with my patients is, we do primarily posterior approach total hips. And I know that's kind of the old school. I know a lot of surgeons may, opt for doing anterior total hips, and they tell their patients that they may not have precautions because it's a functional position. But with our posterior approach hips, we emphasize, when they're lying supine or in a hook line position, we emphasize external rotation of the hips and hook line. And what that does is it starts to engage some of the musculature that they haven't used in a long time. And it's amazing when someone who hasn't been able to externally rotate their hips all of a sudden can lie in that supine position and put their feet together and open their legs, and they actually can, rotate in the cup. They just, people sometimes just burst into tears because that gives them back that function that they've lost. The other thing with that, if you palpate along the adductors and especially adductor magnus, you'll see how tight some of these patients are. And I think that with our total hips, we need to remember to focus on, not just iliopsoas as a hip flexor, but also how tight iliopsoas can get, because it does attach to the transverse processes of the spine. And a lot of our hip patients have developed these very, for lack of a better word, very awkward gait sequences. And so we have to kind of get them to a point where they can move the correct way, where their hip is actually rotating as opposed to rotating at the pelvis to advance their leg, and to get the back, in a more neutral position, as opposed to that increased lordosis that can come with a tight hip flexor muscle.
Okay. So if we're staying on the theme of incontinence, are there any exercises or activities that should be avoided other than the common precautions that you'd see with the posterior hip?
Well, when you're talking about incontinence, that's a big concern with our geriatric population, and so the first thing to do is to get them on a schedule. When you're in the hospital for your arthroplasty surgery, what can happen is you can be hydrated more because of the surgery. And so it's very common that when people are discharged from the hospital, they have to urinate quite a bit. They're, diuresing a lot of fluids, and they're going to the bathroom quite frequently. And so, we start working with them on a schedule of, toileting. If their fear is about how fast they can get up, how fast they can get to a bathroom, then obviously the bedside commode, first and foremost, we get them transferring to the bedside commode. And then that way they develop that confidence to be able to get up and to get to the bathroom and to be able to void. There's nothing wrong with doing some pelvic floor exercises and having them work on Kegel exercises for female patients. But I think, again, a lot of the issues are more of a mechanical issue that, when a patient can't get to the bathroom as quickly as they'd like. So I, tend to try to problem solve the mechanics of it. Let's make it easier for you to get to a close place, and then we can start working on the ambulation and the mobility so that you can actually get into your regular bathroom and go from there.
Yeah, that's a good point. And Nicole, if you are listening, I would definitely reference the podcast I did with Sarah Haig and Sean Hagee titled Pants Not Pads. It was going off of their CSM presentation from 2016, but we touched on a few of those things, not specific to total hip replacements, but I think would be good for that issue. So Jessica Corey, she asked, are there any suggestions for, when you're working with a patient that has had a total hip replacement, when the glutes and or hip abductors just aren't coming back? Sure, you get that a lot in your courses.
Well, yeah, and so the first question is, what type of anesthesia do they have? When you talk about, are they coming back, are you talking about for stability? Or are you talking about, this person has some actual, palsy? What are you talking about? And, when you're working with your patient, it's all about that stability. So I spend a lot of time with my patients once we get them up and standing, once they can actually, move. Our patients move very fast. So I have to kind of back it up a little bit. If, someone has a patient who's not moving very fast, our patients are out of the hospital, next day. I know there's some people that even do same day, but when the glutes and the hip abductors aren't firing, the first question you want to ask is, Is there some sort of neuro involvement? Are they guarding? Or is it a weakness that this patient hasn't used these muscles? So what I do is I tend to put these patients in a gravity assisted position to see if they're firing correctly. Once they're upright, I do a lot of mirror work. I love to put a patient in front of the mirror so that they can actually see what they're doing. It helps because it gives them that feedback, and it's things that they can do when I'm not around, because that's going to be the most successful.
Yeah,
I tend to also use a lot of just manual resistance, just to see what kind of firing I'm getting, and also what kind of substitution movements I get.
Nice. So Rich Gaudio, he asked a similar question, but he was wondering if there's any specific literature for hip stability training after a total hip replacement. And he was referring to someone that he's working with where the surgical side, let's say, is in the stance phase. Mm-hmm. And just with the ability to step forward and step backwards with the non-surgical side. So any words of wisdom or literature that you can reference in terms of improving the stance phase stability, for that surgical limb?
I think the main thing with that is that let's use the right leg as our surgery leg. So if I have a patient who has a weak right leg and they can't take a step without that support, then I need to focus on that support first. And that's a person who I'm going to, first of all, keep on a walker just because, or crutches, just because they need that support. They can't depend on that leg 100%. I'm focused more on the quality of their stance, the quality of their planting their leg versus how fast they can walk. And that's contra patients, because patients, once they can walk, they're ready to go and they don't focus on the quality as much. So for a patient who is having a weakness, that's where I might have them in the hall counter, because I actually love doing kitchen work with patients. And I have them work on stepping towards the non-surgery side. That way they're getting that push off on the surgical side. When patients step towards their surgery side, that's where, if they're weak, they're going to let their trunk hinge towards the hip side, and that reinforces improper mechanics. So what we have to do is we have to get them balanced, and we have to get them trusting that stance leg first. It also depends on how early in the sequence you're working on this, because immediate post-op patients, of course, they're going to be weak. I don't expect a patient to really have strength initially. So what I want to work on with a patient is I want to work on that stability. I want to work on their ability to recognize when they're starting to substitute. So those movements are very small. And then having them, obviously supported. So, if a patient has an island in the kitchen across from their sink, being able to, double support, working on stance, working upright, working on usually at that point, again, I like to do manual resistance versus adding in band therapy or any sort of devices right away. I also, for the patient, I like to videotape them with their equipment, because then they can see what they're doing. Everybody's got a smartphone or a phone that's smarter than them. So, so I have them get the iPad out, or I have them get the phone out. And there's actually some great apps that help with, you can videotape and then you can play it back, and you can, show them exactly what they're doing so that they can recognize it.
Yeah, that's a good point. I think a big thing too that I'm seeing, and it came up in a research article, is focused on running in a younger population. I saw it on the Facebooks this week. I didn't get to read the whole article, but the premise does, let's say hip abductor strength, just the objective measure of that strength, does that actually change mechanics in running? And they showed that even though the hip abductors, became stronger from that objective measure, the actual mechanics of the gait pattern of running did not change in a significant manner. And I think about that in our patients, just if I'm doing clamshells or, whatever exercise I'm trying to improve that hip abductor strength. And I may be even able to show that they have gotten stronger. That doesn't guarantee that that's going to work, when they're in their stance phase. And I really like what you brought up of just putting them in, that supportive position and kind of scaling and progressing from there, focusing on, how they're moving.
Right.
And moving
and for example, you mentioned clamshells. Clamshells are a great exercise to do with patients. But, one of the things that I discuss is, and when I'm talking about the gait cycle, is it's that eccentric training that really helps that patient to figure out, how they're using the muscle. So, having that patient be able to do a clamshell and then hold against me giving them some light resistance as they bring that leg back down, then they can really see how they're firing the muscle. Sometimes they do a clamshell and then drop back down. Mm-hmm. And so getting them to, recognize eccentrically how they do that. I think the hardest part for patients is they sometimes think it's these big movements that they have to do, when it's actually the small movements that help them to recognize where their problems are.
What's your take on metronomes? Do you utilize them?
I don't very much, but any tool that you have, I think works out great. If you're talking about stepping to a metronome mm-hmm. or standing to a metronome, if the patient does it correctly, then that's fine. But if the patient's focused on just taking the step and not focused on the quality of the step, then, that's where you can get into a little bit of difficulty. I'm a fan of whatever tool in your toolkit you have, use it.
Yeah.
Use it.
Yeah. And it seems like, this is just anecdotal. So nothing to back this up at all. It's been really helpful with those patients that, are a few weeks post-op and, their pain has gone down dramatically. They're seeing some improvement, but they're kind of at that phase where they still don't trust their surgery, mm-hmm. and they're kind of expecting something to go wrong or expecting pain, mm-hmm. And they have that habit. And I feel the metronome has helped them kind of normalize at least their gait pattern when pain isn't as bad as what they may expect,
right?
As it was previously.
Absolutely. And, when you have a patient, I love doing just some isolated work on different muscle groups. So like if I have a patient who, for example, has a weak hip flexor, that's a patient who I might have them standing at the base of a stair. And then you can use the metronome to have them lift the leg up to place it on the stair and then lower it back down. And lift it up. And it's the quality of being able to clear their foot of that step so that they're not circumducting to bring the leg up. Awesome. And bring it back down. You can kind of do the same thing as a patient gets a little bit stronger. You can have them standing up on the step and then having them lower themselves down to the surgery leg so that they can, step up with their good leg on the side, on the side, and then lower themselves down to stance on the surgery leg, and then making sure that they're not tipping their trunk to hold themselves up. So metronomes, great way to kind of get them dialed into just repeating the activity.
So the clinician that actually got me to think about using a metronome with my home health patients, which I used it all the time with runners, but never thought to use it with my home health patients, is Jeff Musgrave. And he asked a question. So we're going to transition from hips to knees. He says, he's actually a coworker of mine. And he said, clinically, I and many clinicians, I know, just do gentle AP or PA glides at the tibiofemoral joint and or traction in neutral, but especially at in-range flexion after a TKA. Has she used this, or can enlighten us on indications or contraindications for its use? And he was asking that, thinking about whether the ACL is present or absent.
Right, and with the majority of total knees, the ACL is taken out, so there's no ACL.
Okay.
And one of the most important things that you need to know with a knee is it's not an ACL. And we sometimes treat them as that. I have a lot of patients who will go to patellofemoral glides, for example, and no matter how much you get that patella moving, it's not going to free up the quadricep to be able to get that full range of motion. So if you're going to do any sort of manual techniques, you need to get up in the quads and get up in the adductors and free those up. And so I'm a huge fan of myofascial release in the quadriceps and in the adductors. With the other thing you have to know with total knees is that you can have either cruciate sparing or cruciate sacrificing knees. And the difference between the two is that if they choose to sacrifice the PCL, then the stability is given back through a keel or a post, basically on the polyethylene liner, and then a bar or a cam across the condyles of the femoral component. And that prevents translation of the knee joint. So if you're doing some distraction on the joint, you have to be careful because, I've seen that jump. I've seen people jump that keel and cam, and you can dislocate the knee. Yeah, it was something that we saw. I had a lady who she had some laxity in her ligaments, and she was sitting in a recliner chair with her legs out in front of her, and she went to scoot herself, and she just, she jumped the cam and the keel. And so they were able to reduce her, but then the doctor had to go back in and put in a little thicker liner because of the laxity of her ligaments.
Oh boy.
Yeah. So, I think, yes, actually, doing that end range, inflection, contract, relax, pressure on the tibia, and doing some translation of the tibia forward when the patient's in a seated position with the foot planted, I think works really well. But keep in mind that the surgical approach, there's 4 layers of tissue that the surgeons cut through when they do any joint replacement. And then they get down to the joint capsule and open that capsule. And they repair, once they've done the replacement, each one of those layers. And so you're going to get scarring in those tissues. And the way I like to explain it to patients is that your body, your body is sort of like a lasagna. It's multiple. I ruin lasagna for a lot of people. But your body is layers. It's not a capsule. It's not a shell. And each of those layers is interconnected. And that fascia can get tied down. And so the window of opportunity of healing, if you look at the pathophysiology of healing, in about 6 weeks, that's when scar tissue changes. That's when the type of collagen changes. And so we're kind of, we're under the gun to try to gain range of motion with these knees before they become too healed. One of the things that's always made me a little nervous is when I hear of, therapists who are really muscling their patients to get them to, go and breaking up that scar tissue. And I've always thought that if we worked on this stuff earlier and sooner, then we don't have to put our patients through that horrendous pain that some of them have to endure.
Yeah. When you said that took me back to my undergrad days. This has nothing to do with geriatric physical therapy, but I did athletic training in undergrad, and we had a patient. He had a knee surgery, and I cannot remember what type of surgery it was. I'm not even going to try and guess, but I will never forget this because we had a gait belt that was wrapped around this patient's waist, pinning him to the therapy table. And my professor slash athletic trainer that was kind of the head athletic trainer for one of the sports teams was literally just cranking on that knee, and the athlete was like slamming on the table, just like yelling and screaming. And
see, that's just I hate to hear that. I just we do anything to try to get our patients where they need to be, and that was actually one of the things that really drove me in acute care, because I think that we lay the foundation in acute care for what happens moving forward. And so if our focus isn't from the beginning on how important it is to get the range of motion before we really start to strengthen our patients, then we get these patients that get really focused on getting stronger when they just don't have the flexibility. And if you think about the healing that goes on with the scarring, the scar tissue, I tell them they're going to develop scar tissue whether they do everything or nothing. Mm. And what's going to happen is that how focused you are and how good you are at really reaching those milestone goals, that's what's really going to get your range of motion back so that it's the most functional for you.
Yeah. And one thing that I'm struggling with right now is I'm in a situation where I'm seeing more total joint replacements than what I was previously. Uh-huh. And we're heavy on the range of motion early on, and I'm in a home health setting, and so there's plenty of comorbidities. Most of the people that I'm seeing are not the healthiest individuals, and I just keep thinking about their healing rate. How are they healing? And I don't have a way to objectify that or to really gauge how they are healing, and then how far or how hard I can push in terms of a range of motion. Would you have any words of wisdom for someone like me?
Absolutely. I think, like I said, I tend to work off of this 6-week window because many of our patients follow up with their physicians at about 10 days to 2 weeks after surgery and 6 weeks. And one of the questions that also came up, I noticed, was about how soon, patients would have a manipulation under anesthesia. There is literature that suggests that patients who have a manipulation sooner are more likely to have a better outcome. The idea is that if we give our patients some guidance as to what milestones they need to be hitting, if we give them a target and make sure that they hit it, that's going to help to guide it. I actually just did a retrospective on some data. We keep a database on our patients, and I did a retrospective with our biostatistician, and one of the things that we're looking at is that I have never found an article that identified what the recommended range of motion should be at discharge. And so, I've been, if somebody has one, I'll take it. Yeah. But no one's really written an article that says, what should a patient have at discharge? And you ask, and a lot of people say, oh, we shoot for 90, or our patients leave with 80. Well, if a patient, has 90 degrees or more, we are finding that they are doing better. And so setting that goal of 90 degrees for our patients to leave the hospital, gives them the function to be able to clear their foot to get in and out of a car, or to be able to sit down on a toilet or push up from a toilet. There's also literature now that suggests that if, let's see, what was it? It was one of the articles that I quote is Kevin Bruley and Murray Kolber wrote an article about ranges of motion necessary for different functional activities. And I shared that with our occupational therapists, because they needed to be able to translate to the patient why the function was so important. Why do you need 90? Why do you need 110? Why do you need 120? And it discussed that, to be able to clear a step without leaning off to one side, you need to have about 117 degrees of motion. If you want to squat, which some of our patients do, our patients are very active now, and they want to get back to gardening. They want to get back to reading a putt. They want to get back to playing with their grandkids. And to be able to do those things, you have to have that range of motion. So, we give them that guidance. We tell our patients, we want you at 90 degrees by discharge. We want you at 110 by 2 weeks, and you can do more, but at least 110 by 2 weeks, and then 120 or more by 6 weeks. And by setting those milestones, then the patients have a target to try to reach. The other thing that's out there is there's a lot of discussion about closed chain activities and how beneficial closed chain activities are to range of motion. We've seen that in the outpatient setting. I think there was an article, Lynn Snyder-Mackler had an article that discussed symmetry post-operatively in patients and trying to create symmetry. And that's one of the things that's always kind of stuck with me is that, these patients who gain the motion, they've got to use the motion. So a patient who's, putting their leg in extension to sit down is not going to keep that range of motion. They've got to plant the foot. They've got to do closed chain activities to maintain that range of motion. And that in turn, will help them to keep making more and more function.
Okay. That makes sense.
The other thing that I look for is, I would love to see, I always ask my students, I always say, what's more important in total knee is, flexion or extension? And a lot of people will say, oh, extension. And that's because you need, extension to be able to go through the gait cycle and to take, pressure off the low back, in stance. And, I get a few people that say, oh, flexion's more important because you need the flexion to be able to, be functional and to move. And, I like to say it's the end ranges of motion that you need because our patients are always going to camp out in the middle because that's the position of comfort. But they're both equally important. You've got to get a patient into full extension, and then you've got to get them to maximize that flexibility.
That's a good point. So we've kind of hit on Kathy Shirley's question, but she was talking about just kind of the strength versus range of motion focus. I'm curious, at what point does strength become more of a priority than range of motion? Or how do you view that? I think strength is one of those words that is just such a generalized term because the way that we use it as therapists and the way that patients see it are two different things. Strength for a patient is, being able to be like a hero. They think that strength is, that they're just overpowering something. And when we talk about strength, we're talking about just that ability for stability, the strength to have stability in the stance phase or in, stairs or things like that. So I think we have to be a little more guarded about using the word strength. And I think we need to make sure that patients understand that the window of opportunity of range of motion is a very short window. And for that patient to gain as much, you're retraining the nervous system on how to respond to stretch, and you're retraining the body on how to allow itself to stretch. And so I am a huge proponent of stretching, passive and active. I really like patients to do active stretching because that really gives them control. With our knee patients, I like to use a supported lunge where a patient has their foot up on a second step and they're lunging forward to really stretch the knee. And then the more that we give them range of motion in standing, then when they get to the home health and outpatient phases, that's where that therapist is working on more of the proximal musculature to get that to stretch. Okay.
But if I don't get that knee stretching, then it's going to make everything else. We know that a patient's going to have better flexion when they're standing up versus when they're lying down.
Right. Okay.
So that's why in the early phase, you really want to focus on maximizing that flexibility.
What's your take on CPM, on continuous passive motion?
It is the Antichrist. Someone asked me once about CPM and physicians, and I told them it's like that scene in Indiana Jones where he sees the idol sitting on the pedestal. So he takes the bag of sand and he has to swap it out really quick, and hopefully it's the same thing. And that's the way surgeons are with CPMs, because you have to give them something in return that's equally beneficial, that they think is equally beneficial, so that the ball doesn't start rolling at you.
That's hilarious.
Yeah. But the thing about CPMs is, I'm not a fan because you've got to lay down to use it. It's not active, it's not realistic for the average patient. Yeah. And to have to depend on a device, it's not supported in the literature anymore. Many articles have come out, that have said it's not supported. The Choosing Wisely initiative, which is I think a great reference, it specifically states that you don't need to use a CPM for non-complicated total knee. And so active movement, I think, is better for the patient because it gives them the control. But we've got to get them actively moving in the right direction. So that's why, like I said, I'm a big proponent of closed chain activities and, getting that patient doing sit to stands and doing stretches and, having them walk, and practicing that gait sequence. Yeah.
That's good stuff. So Shaylin O'Reilly, she asked a couple questions. So what are your thoughts? I think you hit on this earlier on ideal timing for knee manipulation under anesthesia. She said her clinic has had two cases recently that are over 3 months out from surgery where the surgeon is recommending a manipulation. In my research, I thought the outcomes aren't great that far out. What's your take on that?
Correct. And I agree. The outcomes of manipulation under anesthesia that far out, you run a very high risk of injuring soft tissues and actually of bone fracture. So, and you think about the geriatric population that may already be compromised in terms of their bone integrity, and so earlier is better. If you can, our surgeon will manipulate at 6 weeks. So when the patient comes back for their 6 week follow-up, if they're not where the surgeon wants them, then they will do their manipulation at the 6 week mark. And again, the reasoning behind it is the whole healing of the tissues. There is an article in it's in the Journal of Bone and Joint Surgery. The main author is ISA, it's ISSA, and they talk about manipulations under anesthesia and the effective timing. And the thing that they point out is that the threshold for performing manipulations is within 12 weeks. So, we're manipulating at 6, but at 12 weeks out, that's right at the end of when that patient's tissues are healed. That collagen is dense. And so you're struggling between actually injuring other soft tissues that can be to the detriment of the patient.
Man. So Shaylin also asked a question so we'll move on to total ankles, which I still have not had a patient that has had the surgery, but she says, any info on total ankles in terms of range of motion or functional expectations? It's not as common in her area, but she's starting to see more and want to have a better understanding of what is realistic in terms of recovery and fair quality.
Yeah. Being in acute care, that phase of care, we're not seeing anything that we have an effect on. But if I have to give anybody advice on total ankles, I would recommend actually having the rep for the company come in and talk to your rehab department or talk to your therapy staff about the surgery, talk about the expected timing of healing, talk about their particular implant and expectations on, advancing the program. Because a lot of the time, as much as I think in drugs and things like that, it can be more biased. I think with the implant companies, they really can give you some insight on how quickly to advance these patients. The other thing is when I do searches online, I was joking that I'm that person who sits in front of the television with my computer on my lap, pulling stuff up as I hear it. When I do research on anything, the first thing I do is I look for a protocol online. And just when I saw Shaylin's question, I actually went online and started looking up some total ankle protocols. And a lot of the protocols, have limited weight bearing for at least the first, non-weight bearing for at least the first 6 weeks. And then they will start them in on some range of motion activities. And, the total ankle, when I first started in joint replacement, they were just starting to trial some different types of talofibular components. So this is really an area that's still, I think, right on the cusp for a lot of us. There's some people who, work with foot and ankle guys that are doing a lot of these total ankle surgeries. And I'm sure that they can give you some better ideas. But as far as I'm concerned, I'm huge on having the reps do in-servicing. I'll go online and pull up the protocols. And actually, if you have the ability to go into the OR with your docs, definitely do that, because I think it's a great time to see what they do, be able to pick their brain a little bit, and that way you can run some things past them.
Yeah, that's a good point.
Yeah. The other thing is actually, is putting off some protocols or getting those protocols to the docs, because the docs will tell you what they do in any surgery. Whether it's a shoulder or a knee or a hip or an ankle, they're the ones who know what the integrity of the tissues are. They know what the implants that they use, the suturing that they do internally, and they know what's going to hold. Because I've had, for example, total shoulders where, you talk about healing on total shoulders and the, how quickly you advance someone through their protocol. And, I remember teaching down in Miami and discussing protocols and the length of time that, a surgeon might restrict external rotation over, an 8 to 12 week period. And I had a therapist raise their hand and say, our surgeon, has no restrictions right out of the gate. And everybody was kind of surprised. And they said, well, the surgeon, gets a really good approximation of subscapularis, and they feel that holds. And so for that particular surgeon, they're very liberal on what they allow their patients to do. So, while you always want to be mindful of your particular surgeon and finding out what their restrictions are, I think that, getting them into getting the people that know the implants into in-service and then putting you in touch with people, I think that that's a really good way to figure out what you're going to do with these patients.
That's a good point. Well, that's it for the questions. Man, you knocked those out of the park, Alisa. Well, I'm impressed.
Oh, stop.
I'm impressed. Well, I want to be respectful of your time, and I'm going to end just with one more question.
Sure.
It's my favorite question.
Oh, is this like the guy on what's the show? Oh man, I love the show too. He interviews the celebrities and then he asks them, what would you like God to say when you enter the pearly gates? James Lipton, that's the guy.
This is the geriatric rehab version of that. So,
oh, I love it.
So if, let's say we're at CSM and you've got every geriatric rehab clinician in the room, you have their attention. What would you want them to know?
I like to emphasize that, these patients have lived a long time without us. And they are going to teach us a lot about them. And so our job is to adapt to them, not them to adapt to us. We need to respect the fact that, they've got their habits and they've got their routines. And realistically, these patients in joint arthroplasty, there's a lot of advances that have been made. And we can get these patients back to being highly functional. Just thinking of patients who want to go back to golfing, traveling, all the things that they love to do, fishing, whatever it is, getting back to work even, they're still working later. And so a lot of times I think that if we focus on their flexibility, their mobility, that's what they need as they age. They need to remain flexible. They need to maintain the integrity of their joints. And this is a safety net for them to be able to get that joint motion back. So what we have to do is we have to make sure that they maintain that. Our patients that do yoga, things like that, those are the ones that are, staying healthier for longer because they're moving. And so we need to keep these people moving.
Preach it.
We can always, I'm sorry, Dustin, I was just going to say, we can always get them stronger, but we can't always get them flexible in joints. So that's why I opt for flexibility over strength. But strength is highly important. Strength is highly important.
Yeah. Well, Lisa, thank you for your time and answering all those questions and just giving us a better insight into just so many patients that we see. It's been really helpful. So if people have questions, I highly encourage you to join the Senior Rehab Project Facebook group. Elisa's in there as well as several other really smart people. You can also, join the special interest group, and I'll put a link to that as well. And then any other way that you would like people to contact you, Alisa, or you want to stick with the Facebook and spatial interest?
I would actually highly encourage people to join the Total Joint Therapist group it's all one word. It's Total Joint Therapists, plural, at yahoogroups.com. If they send a message to that they want to join, I'll put them in there. It's a great way for you to have a dialogue with therapists all around the country that are doing joint replacement. I'll be the first one to tell you that I've been fortunate to do this for a long time, but there's also a lot of therapists out there who are equally as talented, and we all have our own bag of tricks. And the more that we share that, and the more that we open the dialogue, I think that I think that altogether we're going to take the best care of the patient.
Yeah, awesome. All right, so I'll put a link to that in the show notes, and everything that we mentioned. And once again, Lisa, thank you for your time. I appreciate it.
Keep doing. This is a great thing you got going. So keep up the good work.
I'm gonna try.
This is awesome. Thanks a lot.
Hit me. Thank you for listening to the Senior Rehab Podcast. If you enjoy this content, I highly encourage you to go to seniorrehabproject.com, where you can find more helpful episodes, lots of free resources, and to see how you can become a game changer and influence the direction of this movement. I appreciate you, and I'll talk with you soon. But in the meantime, do not forget to stay funky.
This podcast is sponsored by Great Seminars and Books. Have you ever thought about how we can become leaders in geriatric care, or how we can break out of the silos of rehab to serve older adults to the best of our ability? Well, myself and Dr. Carole Lewis of Great Seminars and Books will be holding a free webinar titled Breaking Out of the Clinic: Strategies to Become Leaders in Geriatric Care. This webinar will take place on October 9th, 2017 at 7 p.m. Eastern Standard Time. To get access to this webinar, just go to seniorrehabproject.com/great. This podcast is brought to you in partnership with the Geros Collective, a podcast network that's redefining old and equipping healthcare clinicians to better serve our aging population. Find out more at geroscollective.com.